Good morning, good afternoon, good evening, depending on where you are. Welcome to this webinar that we are organizing today, entitled Optimizing Community Health Workers Programs, Innovative Strategies and Insights. This webinar series is organized by the International Institute for Primary Healthcare in partnership with JSI and AMREF. And we have great speakers today from WHO, from the Ethiopian Ministries of Health, JSI and AMREF. My name is Antana. I'm the Director of Programs at the International Institute for Primary Healthcare. I'll be moderating our sessions for today. We will be sharing the global perspective on primary healthcare reform, and we'll go deep dive into the optimizations within Ethiopia and then try to see at sub-national level, both in the agrarian and pastoralist communities. We partner with JSI and AMREF with the Integrated Primary Healthcare Service Delivery Program, which the speakers will be mentioning later on, and that we want to share the lessons from the field and what the meaning in terms of, HEP optimization at the community level. Let me start with, saying a few words about the International Institute for Primary Healthcare. I know most of you have been participating in the past on a similar webinar series and know about the institute. The International Institute is established by the Ethiopian Ministry of Health back in 2016. We envisioned to become a center of excellence in primary health care. We have been supporting the national ministry through different capacity building and also global capacity and strengthening through experience sharing, designing different courses, and engaged in knowledge generation as well as advocacy. If I say briefly about the International Institute, without taking my time, I'll proceed to introduce our first speaker, who is Dr. Faraz Khalid from the WHO. Dr. Faraz Khalid is currently a Research and Innovation Officer as a Special Program for Primary Healthcare at WHO headquarters. And before this role, he was responsible for coordination of universal health coverage reforms at the WHO's Eastern Mediterranean Regional Office, where he supported 14 countries across the region. He has taken multiple roles in the low and middle income countries' health system in the last 17 years. He started his career as medical doctor, transitioned to a program manager of an award-winning innovative mHealth, enabled social health protection program in Pakistan. He has worked as health system and financing consultant for WHO, UNICEF, Asian Development Bank, and USAID. Following his medical training, he completed his PhD in Global Health Policy and Management from Tulane School of Public Health and Tropical Medicine, USA, and did Masters in Public Health from London School of Hygiene and Tropical Medicine. Welcome, Dr. Faraz, and over to you.
Thanks, Anthony. First, let me confirm, can you hear and see me?
Yes, we can hear you and see you.
All right, great. Indeed, it's a privilege being with this group. I already see the increasing number of participants, and I think that speaks of how this series of webinars is being valued, if not only in Ethiopia, but across the continent. So that seemed very promising. Thanks, Anthony and the organizers for this opportunity. Let me share my screen. Let's start the presentation. Anthony, can you please confirm if you can see my slides in presentation mode?
Yes, we can see that.
All right, great. So as we dive into this subject today, I was discussing with Anthony that it would be useful for us to have a big picture view of reforms happening across the globe on primary healthcare or implementing the PHC approach, so that we can then plug in where do the current focus, the focus of today's agenda, how does it fit into broader PHC reforms? And then overall society systems and societal goals. So for that, I'm sharing with you the recently released a global health report on primary healthcare titled Implementing the PHC Approach, a primer. I'm presenting this on behalf of 6 co-editors, approximately 70 authors and contributors across 6 WHO regions. First, it's important, I think, as we navigate through this journey of PHC reforms and what have been some global milestone reports and declarations, which has also informed, inspired, but also mapped and captured different reforms happening on the PHC agenda. May it be Declaration of Alma-Ata in 1978, 2008 World Health Report on PHC, now more than ever, 2010 World Health Report on Health System Financing, 2016 report on Integrated People Health Center Services, and 2018's Declaration of Astana. As I said, these global documents, they're not necessarily the all, because there's a lot which has happened over the time at the regional and country level and different subnational movements, which have led to where do we stand on PHC at, as I said, subnational, national, global levels. Further, looking at again some of the key global primary healthcare related projects, as I mentioned, Declaration of Astana, the vision for primary healthcare in 21st century, operational framework on PHC, and in 2022, the primary healthcare monitoring framework in indicators. It's as I said, from the vision to operationalizing it, and then how, when we're operationalizing it, how do we measure and monitor that? That also includes an important component of primary healthcare workforce. But it's important to see where workforce sits within the overall systems PHC-oriented thinking. A quote from Dr. Tedros saying PHC is one of the most important concepts in public health, but yet it also one of the most misunderstood. And hence, we think it's important to understand what PHC approach means in its systems perspective. Here, the aim of this global report was to cultivate a common understanding of PHC, elaborating on strategies and actions within each lever, including the lever on primary healthcare workforce, but also emphasizing the potential of PHC to achieve health system objectives and health system performance, but also identifying common enablers and barriers to advance PHC. Within this primer, one point I want to highlight here is that it has captured more than 50 country examples on implementing the PHC approach globally. It has 3 parts. One is more around PHC, its foundation, history, concept. Second is more around operational levers, and then how it helps health systems transition towards PHC models of integrated care. That includes primary healthcare workforce. And then the third important component part being reflecting the ability of PHC to achieve health system objectives, because it's always also often questioned that PHC is more an inspiration, ideology, philosophy. What impact does it really have on ground? And here in this part, it has been shown that how does PHC has an impact on systems objectives like equity, efficiency, financial protection, quality, resilience. It has, as I said, the first part I want to highlight with more of interest to this group here is that other than, as I said, recapping the foundation and history and concepts of primary healthcare, it also brings forth some country illustration of that how in Brazil, the family health strategy has been pivotal for improved health sector performance. How in Ethiopia, there have been improved health outcomes through sustained efforts in health sector investments. How in Lithuania, there have been links which have been fostered between public health and primary care elements per level. How in Slovenia, primary care and public health it has been integrated through a community-based, person-centered PHC model. How in Bangladesh, community health workers as first point of contact in community clinics been playing an important role in improving the system's performance. How in Iran, a strong network of community health workers and multidisciplinary teams have been allowing a multi-tiered referral system. Again, that's not an exhaustive list in the main report. More country illustrations are there in the part one. In part two, which would be also of quite relevance to this group, where we talk more about PHC operational levers and how they have been implemented to align with PHC orientation of the system reforms. And it does include different country illustrations, maybe from Costa Rica, where on governance, there's a case study on decentralized decision-making with a strong national tier. Then I've listed here about 4 or 5 country illustrations captured in the chapter on primary healthcare workforce, where how autonomous working in teams as a basis for attracting working in environments, the famous Buurtzorg model in Netherlands, has been very effective. Secondly, also in Zambia, how employing community health workers has allowed greater community participation. In case of Albania, how investments in training and education has been helping fit for purpose primary care workforce. How in Finland, a sufficient supply of healthcare workers has been secured through new advanced practice roles and division of labor. So I'm sure for this group, these country case studies, which are more geared towards primary healthcare workforce, would be very relevant. But also within this part, there have been some country illustrations on other levers, let's say on financing, how in Afghanistan, financing primary healthcare and fragile state has been affected. In India, raising awareness and acceptability and affordability through a generic medicine program has been effective. In Mongolia, mobile health clinics have been bringing primary care to vulnerable communities. In Ghana, how IPC and WASH agenda has been neatly brought into primary healthcare oriented reforms through multi-sectoral approaches. In South Africa, how a mobile health application has been fostering health information exchange, again, using the PHC approach. And as I said, it's also important to document the impact of what we do. And in this case, I just mentioned a few in how in China, expanding coverage through primary healthcare has been improving the effectiveness, efficiency, and user satisfaction. In Thailand, transition to a PHC-oriented system, how it has been effective for equity, access, and financial protection. In Spain, our strong primary healthcare-oriented policy has been proven useful for reducing inequity, and financial hardship. But also in Mexico, how primary healthcare has been useful for improving health system resilience, especially during the COVID-19 pandemic. But also bringing in an example from Canada, that how environmental sustainability has been incorporated into their PHC-oriented reforms. Again, these are only a few illustrations. There's a lot more in the report. Well, briefly capturing, we also understand that these global products, they're important and useful to inform, but we are also mindful that they may not be enough for us to take the dialogue at the country level, like national and subnational level. And hence, we have distilled not only from this primer, but other sources, a case country, PHC country states compendium, which has country case studies from more than 100 countries and a compilation of around 250 on a web-based repository. And I'll share the link in the chat soon. Then we'll be soon launching a global PHC leadership course. This first global report will be supplemented by the subsequent global reports, which will be more focused on measuring the performance using PHC and FI capacity, performance, and impact, but also through a series of implementation stories, a webinar series. So a lot more to come, and linking this evidence synthesis and knowledge management with their policy to action could be harnessed. Well, it's a broad list of different contributors which have contributed to this. Let me stop here for a quick overview of how in a global report we have captured different PHC-related reforms. I'll be sharing the link in the chat, both for the global report, but also in case study companion. And as needed, I will happily be available in the next 45 minutes to reflect on any questions and comments you may have. Back to you, Andrew. Thanks again for the opportunity.
Thank you so much, Farad. That was wonderful. And, having this, the premier, particularly with several countries' case studies, helps to demonstrate, the impact as well as the implementation of primary healthcare. And with the other products, it really means one of the things the Institute has been doing is providing different leadership courses focused on primary healthcare. And that's another area where IPHC would like to continue the collaboration with a special program. I don't see any question coming directly to you at this point. I really would like to thank you for going through the premiere and covering what it consists of, the concepts, the history in terms of implementation and impact on performance. We will be sharing the link to those products as well. If you check on the chat, you'll find those links. Thank you, Faraz. Okay. Bru, if I don't miss anything, if there is no question, I think I can proceed to introducing the second speaker.
Yeah, sure.
Okay. Now we have invited a speaker from the Ethiopian Ministry of Health to share with us the Ethiopian experience in terms of the HEP optimization. Allow me to introduce Wendesen Gato. Wendesen Gato is a public health professional by training, and he has over 18 years of extensive experience at direct district and national level. Currently, he is working as a head of community engagement and health extension service desk under the Community Engagement and Primary Health Care Lead Executive Office, Ministry of Health of Ethiopia. He is responsible to lead and coordinate the implementation of health extension program, optimization plan, and review and evaluate the health extension program and primary healthcare activities, prepare periodic activities, reports, coordinate the human resource working in the team, and provide technical support to the regional health bureaus. He is passionate about health extension program in primary healthcare, and he has leadership qualities and great at working with the teams. Welcome, Wendesen, and over to you.
Thank you, Dr. Antony, for the brief introduction. Can you see the slides?
Not yet.
Maybe I can share the slides if you want.
Yeah, I think in the interest of time, that would be great, bro, if you can share it.
I have shared the screen.
Sorry for
We
the
can-
inconvenience. Thank you again for the introduction. I'll be giving you a brief information on the health extension program optimization. I think everybody participating in this webinar know more about the health extension related and health extension program. And I'll be putting some information about what is happening on the health extension program right now. So these are the outlines that I'm going to cover in this presentation. Next slide. As you all know, Ethiopia is one of the African countries which is situated in the eastern part of the continent, with having an area of 1.1 million square meter and total population more than 110 million. And there are 12 regional government and 2 city administrations. Regarding their facilities, we have about 17,864 health posts and nearly 4,000 health center and 400 health hospitals. So health extension program is introduced in 2003 in our country. It is basically provide basic and essential promotive and preventive services for the community, especially for the rural part of the country. Initially, it was started in a rural part of the country, and later in 2003, later it is scaled up to the urban setting and pastoral settings. So currently, the extension program is working in all parts of the country, basically at the rural parts and urban part of the country. And the extension workers who are 12 or 10th grade graduates who have trained on basic health extension program for 1 year. So they are deployed at Kabale level and provide different basic health promotive, preventive, and curative services for the communities. Next, sorry. So following its implementation, after the extension program is implemented for about 15 years, a robust health extension program assessment has been conducted in 2019. So this assessment has brought several findings that will help us to improve the performance of the extension program as a whole and to strengthen the primary health care service of the country. So the major finding is that the finding brings is one the communicable and maternal neonatal and nutritional disorders are the largest disease burdens of the population still, and the other providing the clinical service specially which are expected to be provided at the health post level with the current existing health infrastructure, health post and workforce result the compromisation of quality of care. So in order to address these gaps, these issues, there should be some sort of intervention that will improve the service provision as well as to keep the health of the community. Next. So while the health extension program roadmap was developed, there are several steps. One of the most important things that was done is the assessment that I mentioned earlier. The situations of the health extension program implementation was assessed, especially regarding the facility, relevance of the facility, relevance of the services, and relevance of the health workforce. And the other thing, the benchmarking, especially the desk review, that on the international and local benchmarking has been done during the assessment, and different consultative workshops with the relevant stakeholders here in the country have been conducted to enrich the assessment. So the goal of the health extension roadmap is to accelerate the realization of universal health coverage, through which everyone will have access to the needs, the health needs, especially the prevention, promotion, and treatment of the different cases. So this roadmap will help to realize the universal health coverage. Next. So there are rationales. Why do we optimize the health extension program? Why don't we maintain the existing health extension program? So one of the rationale for the development of the health extension program roadmap was the changes in the health extension program need more structured guidance. It need to be laid in a structured way. So this is one of the rationale for the development. And the other is the challenges and opportunities that happen following the socio-economic changes are the other factors that drive the development of the roadmap. And as you all know, the changes in cause of preventable morbidity and mortality of different cases. The changes are also a pushing factor for the development of this roadmap. And the community awareness is increasing regularly. So if you take before the introduction of the health extension program, the awareness of the expectation of the community was not that much. But following the health extension program introduction, the community expects more about their health, and they want to get quality of care and services from different health facilities. So this is the other rationale for the health optimization. And the commitment to universal health coverage is given, and we need to expand the essential health service package. So this is the other. And the need to address implementation challenges. There are, even though there are several results that the extension program brings, that there are also challenges while we implement the health extension program. So this is also one of the factors for the development of the roadmap. Next. The roadmap has 6 strategic objectives. One is ensuring equitable access. So to ensure equitable essential access to the community, we need to expand the health extension program package to different parts of the country and the community. So we need to also establish community health programs at different facilities like health centers and hospitals. So in order to ensure this equitable access, we need to do several things. This is one of the strategic objectives. The other thing is the quality of health services. So in order to provide quality of health services through the health extension program, we need to have a competent and compassionate workforce, and we need to have enough supplies and the infrastructure. Most of the infrastructures, especially those that are constructed during the introduction of health extension program, are basically made from local materials, and some of them are getting older and older. So we need to renovate the infrastructure. So this is one of the factors for the strategic objective for the development of this roadmap. And the other thing, sustainable financing. So the government should also prioritize the spending at PHC level. This is other strategic objective. And the other, community engagement. As you know, community engagement, Ethiopia is a model for community engagement. We have several platforms for engaging the community. So we need also to redesign the existing community engagement platform. So this is one of the strategic objectives. And ensuring resilience by maintaining the provision of essential services during any health emergency. This is the most critical, and we have also learned a lot of lessons during the COVID pandemic. So we need to define and standardize the role of health extension program, especially in emergency preparedness and response. So this is the roadmap also helps to address these issues. And the other thing, the political leadership. So a strong political leadership and multi-sectoral engagement is very crucial in strengthening the extension program. So this is one of the strategic objectives that is identified in this roadmap. Next. So there are shifts in this roadmap. So what makes it different from the previous health extension program? There is an expansion of services and the target groups in this roadmap. So the services, regarding the services, there are some curative services which are shifted to the health post, especially at health posts which are meant to be a comprehensive health post. So the other thing, reaching out the marginalized population or a group of population who are living far from other facilities like health center, hospital, and the like. So we need to expand the service to the community, and the how part to expanding these services is in this roadmap. The health posts will be categorized into two categories. Actually, it's three, but one of the category will be dissolved. So one of the categories comprehensive health post, a health post which is situated far from the supervising health center or primary hospital, and it's expected to provide all the health extension program package and some curative service for the adult population. So in terms of equity and provide quality, this will be very crucial. And the other, the basic health post, which is found near to the health center, and will be expected to provide the basic health extension program packages. And the other health post, which is very near to the health facilities, other health facilities like primary hospital or health center, it will be integrated or merged to the existing health facility. And the health extension workers who are working in this health post will be providing the community health services, integrating with the health center facility, the health center healthcare workers. So in general, we'll be having, after all, we'll be having two kinds of health posts, basic and comprehensive. The merger will be considered with the existing other facility, which is it could be primary hospital or health center. Next. So after the development of the roadmap, what we do so far is the first thing that we did, launching and advocating the roadmap. It was nationally launched with the presence of the government higher officials. So after it is launched at national level, the launching and the advocacy continued to the regional level. And following this, different guiding and supporting documents like the implementation manual, the post reform implementation manual, and other supporting documents were developed and communicated to the regions in order to utilize it accordingly. And the other thing that we did, categorization of the existing health posts. So except the Tigray region, the existing health posts are categorized as the figure that you see in this presentation. And we have currently 12,470 basic health posts, comprehensive 1,873, and the merged one 2,555. So after categorizing the existing health posts, we have tried to scale up implement the roadmap. So far, with the effort of the government, the federal government and the regional states, about 107 comprehensive health posts has started providing a comprehensive health service as per the roadmap, and 3,522 basic health posts also started to provide service. And among the 2,555 health posts that are identified to be merged to the nearby health facility, about 1,900 are merged and providing the service, community service, and service that are provided at health facility. So following this also, there is also a construction of health posters. This construction is also basically with the effort of the regional governments and the federal. So far, 201 comprehensive health posters are under construction in especially 4 or 5 regions. Of course, there are regions who are not working aggressively in constructing their posters. Among this, 84 completed and 41 basic health posters are also under construction. So these are some of the practical activities that we did after the introduction of the roadmap. Next. So the other thing, the community engagement. So one of the findings that I tried to mention in the introduction, as you know, in 1960s, there were several community engagement platforms. So recently in 2011, the Ministry of Health has developed the community engagement platform, the so-called HDA or WDA. We are using these words interchangeably. So the Women Development Group, the 1 to 13, 1 to 5 network, this is organized at Kabale level through the support of the Kabale administrators and the health extension workers. So this platform has been provided a competency-based training which focus on the basic health extension program packages. So far, we have tried to train about 1.23 million WDG leaders on the basic health extension program package. And recently, in 2029, we tried to revitalize the community engagement approach, which is a redesigned community engagement approach. So which contains the most important thing, optimizing the existing WDG platform. So it needs to be optimized. And the other one is introducing another cadre, which is VHL, Village Health Leaders. These Village Health Leaders are recruited from Kabale. A single VHL is expected to provide and oversee 3 to 4 WDGs. So this also took training, capacity building training, and then the existing, which meant to be established for the agricultural sector, the male development group. So we need to also engage the male development group for the health activities. The other, the youth engagement. Youth, as you know, almost 50% of the population, nearly 50% is youth. So we need to engage youth for the health activities. And the other social structures, which are like locally available in different, for example, in our country, in every region, there are different social structures, which are very crucial and influential to disseminate health messages and support the community. So we need to also engage all these structures. This is part and parcel of the redesigned community engagement approach. So far, we have tried to implement the redesigned community engagement platform in 124 waradas. And still the implementation is very slow. So we need to scale up and we need to cover all the waradas. And we need to also design a community engagement platform for the urban setting. This basically works for the urban, rural, and agrarian and pastoral. So we need to also design a community engagement platform for urban settings. Next. So this is very common. The achievements that gained through the health extension program is well understood. You know, the health literacy, health system literacy, and the reduction of communicable disease, the service uptake, and several. These are some of the achievements that we gained through the health extension program. Next. So the challenges are, one of the challenges that we are facing in implementing the health extension program is shortage of essential medicines, medical supplies for the health posters. And This is very critical, and the other is the infrastructure. As I told you, the existing health posts, about 65% of the health posts are made from locally available material, and they are getting older. It was constructed about 15 and more than 15 years ago. So we need to revisit and renovate it. So the poor infrastructure of the existing health post is one of the challenges that we are currently facing. The multi-sectoral collaboration also, that's another issue, and resource, especially in implementing the 15 years roadmap. We need to have enough resource, because the most important thing in terms of resource in this roadmap is the health infrastructure. So to build the new health posts, both basic and comprehensive, we need to have enough resource. HR, medical supplies, and equipment. These are the most important critical challenges that we are facing. I think I've tried to rush and use my time effectively. Thank you very much. Thank you. If you have a question, I would be.
Thank you so much, Wendasan, for the nice presentation, sharing the moments, for the need for the health extension program optimization, and taking us through the histories, and as well as the 2019 national assessment findings, and how we started to strategize to address the challenge of quality, access, and equity, and having, the objective of in addressing the issue of equity and quality, as well as financial risk protection and sustainable financing, empowering communities and the resources. And the main strategies being the reforms and the recategorization of the health post and the community engagement approach. We have a couple of questions that we have seen. You can put your questions on the Q&A chat board, and we will try to address them one by one, and some would be addressed live by the speakers. Thank you very much. Without taking my time, I will proceed to our next speaker, Dasalo Mawai from JSI. Dasalo Mawai is a project director at JSI L10K for the C-funded health extension program performance improvement project, and the newly gets awarded improving primary healthcare service delivery project. Dasalo has nearly 20 years of progressive experience in program management and technical leadership in community and primary healthcare systems, reproductive, maternal, newborn and child health, community engagement, and digital health programs. Before taking the project leadership role at JSI, Dasalo served as project director at Mary Stopes International Ethiopia for DFID-funded, now FCDO-funded, family planning project. Prior to the Mary Stopes International, he served at JSI L10K as PHC team lead and RMNSH technical advisor and regional manager positions. During his earlier careers, he also worked as a reproductive health program at Engender Health in Ethiopia, and took different positions in the government health system, starting from healthcare facilities as primary healthcare director, health science college lecturer, and reproductive health program officer at Amhara Regional Health Bureau. Dasalo has a BSc from Alamaya University and an MPhD degree from Addis Ababa University. Welcome again. Over to you, Dasalo.
Hi, everyone. Good morning, good afternoon. Thank you, Dr. Antonio, for generous introduction. And thank you, everyone, for your interest in joining our webinar, which is focusing on optimizing community health program. So I will be presenting on optimizing community health program in Ethiopia through networking primary healthcare facilities and communities, which is one of our implementation strategies we designed and tested in selected districts as part of the national effort in optimizing the health extension program. So I will be very brief, focusing on this network of care model in improving community health program in Ethiopia. I'll be briefly discussing some of the highlights of our learning in implementing different implementation strategies and some key takeaways towards the end of my presentation. Can you hear me, just to confirm?
Yes, we can hear you, Desal. We can proceed.
Thank you. Thank you. So one of the first investment to support the ministry in operationalizing the health extension optimization roadmap, improving primary health care service delivery project, funded by the Gates Foundation and implemented by GSI and AMREF in different Ethiopian contexts. So following the launching of the optimization roadmap in 2021, this award has been made in 2022, and we have been implemented for the last about 2 years, nearly 2 years. So the roadmap, as Wondoson said, constitute about 6 pillars, but this investment focused on 3 of them, which includes access, quality, and community engagement and accountability of primary health care. We're implementing about 14 districts in 9 regions, but we will be spreading to additional 30 waradas. So I'll be focusing on this investment that we were pressure testing the roadmap in selected waradas in agrarian settings. Probably Tamasgen later may add the pastoral context. So I will be limiting this presentation to the agrarian context. So for this presentation, we used the program management information system, facility records, and some qualitative data that we collected from program managers, providers, and claims. So one of the innovations that we designed and implemented was a network of care. That is a kind of group of public and private facilities or service delivery sites deliberately interconnected through administrative and clinical management model, which promotes structure and culture that prioritize the client-centered, effective, efficient operation and collaborative learning, and enabling providers across levels of care, which means from community to primary hospital in Ethiopian context, and including the community, to work in teams and share responsibility for improved health outcomes across their catchment population. So it has 4 domains, which includes purposive arrangement, which means arranging facilities, primary healthcare facilities, both public and private, and communities in a district, and they established a network of care arrangement, and they set common goal and sign memorandum of understanding to support each other, and they define operational standards, including mapping resources. They exchange supplies and resources, active referral management, integrate community engagement and community health programs at health center and primary hospital to support the health extension program. And they do have, this is the quality and accountability domain, including quality improvement processes, both at the facility and community levels, technical oversight and governance, and they implement community engagement strategies that Wondoson has mentioned earlier. And they do have, in terms of learning and adaptation, performance reviews, collaborative learning, and mentorship among facilities in a district. So ultimately, this will bring optimizing the health extension program and improving bidirectional linkage, trustful relationships across primary care facilities, and improve coordination of care, and ultimately will improve quality of RM research outcomes. This is the hypothesis or the framework that we tested. So one of the key measures of this arrangement was its functionality, which improved better coordination and relationships among primary care facilities between, it's a kind of horizontal relationship between primary care facilities, which constitutes primary hospital and primary health care units, which means in Ethiopian context, the health center and satellite health posts and communities. and they will work together to improve health outcomes. So functionality constitutes dozens of indicators related to this network of care, which includes implementation of clinical standards, resource sharing, governance, functionality of community health systems, bidirectional accountability, referral, improving access, learning, capacity building, mentorship, and so on and so forth. So we, developed a matrix, a composite score, and over the last 1.5 years, this shows improvement in terms of functionality, and we are also developing maturity index or maturity measures for the network of care in the district. So this process helped to improve community health program, establishment of community health program at health center and primary hospital. That is reorienting the health centers and primary hospitals towards the community health so that they provide support. Again, we developed a functional score, which improved over time. This community health program enabled health centers and primary hospitals to establish a multidisciplinary outreach services, improved linkage with health posts, and improved the community health program in their respective catchment. And sometimes HEWs alone doing outreach and home visit, but usually accompanied by multidisciplinary teams, which includes the midwives, the clinical officers, nurses, and sometimes physicians to do outreach services, especially in those communities which are far from the health center and hospitals. Another strategy is that this network of care arrangement implemented, introduction of the village health leader approach that Wenderson was mentioning earlier, to link communities and families with health extension program and primary health care. As part of the package, we introduced this VHL strategy in agrarian settings. So these VHLs are gender mixed community volunteers that will work closely with community structures, with communities, with women development group, and religious institutions. As you see from the graph, the gender mix, nearly majority of them are female, but there are also men that will deal with the men groups and husbands to address the gender issues and create enabling environment at household level in terms of improving men engagement in the community health program. And most of them are above 6th grade. And so they are able to read and write, and they are serving as an extended arm of the health extension workers, and they share some tasks from HEWs to the community. In terms of functionality, again, this is a community health cadres. About 90% of them deployed so far were functional, which means they do have their own plan. They actively participate in regular meetings with health extension workers on a monthly basis. They conduct home visits and support the women development groups, and they conduct family conversations at family level. The other implementation strategy, this arrangement produced was introduction of the health post reform implementation, which has been adapted from the health center reform implementation guide, adapted to the health post context, which has 7 chapters, which includes community engagement, providing health extension program package services to the community, the human resource, and the infection prevention, leadership management, and working with the Qabli administration, pharmacy, MND, and so forth. So this shows over the last 1.5 years, there was a significant improvement in terms of implementing these reform chapters, especially the community engagement, HEP service delivery, leadership and management. Closely working with the catchment health center and the village administration or the Qabli administration, which is the lowest administrative unit of the government, was, improving over time, but HR and infrastructure remains a challenge as the comprehensive health posts. We collected some qualitative data on the experience of care, obstetric care in comprehensive health posts. Comprehensive health posts are an upgraded version of the health post, which provide expanded package of HEP services, including delivery services. So there are positive reflections from women or users in terms of improved access to skilled birth care, decision-making to seek care, and improved their perception on quality of care, and providers' responsiveness and respectfulness to their clients was, appreciated by the clients. Consented care, involvement in clinical decision-making, community acceptance and trust, and better working environment and satisfaction were reported from the users. So this is a positive experience on obstetric care at comprehensive health posts, but there are also critical challenges and that needs improvement, including the infrastructure and amenities and supplies, access to companion of choice, capacity building and motivation opportunities, especially for nurses and midwives deployed at comprehensive health posts. They don't have equal incentive package as compared to the health center, those working at health center and the hospital. And there are also challenges in terms of manpower, amenities, and supplies related to the infrastructure and power. So another study, independent study conducted by Merck on the productivity of HCWs. So productivity was one of the challenges at health post level and at health center level. Merck in different study conducted, Merck is an independent firm that works on evaluation funded by the foundation as well. So they conducted a time motion study and they compared the productivity of HCWs in IPHC sites and non-IPHC sites. So HCWs in our project sites tend to have more productive time as compared to other typical health posts in elsewhere in other geographies. The other achievement or learning from this network of care is improved bidirectional linkage, which yield improvement in CS delivery rates and complication management related to obstetric care in appropriate primary health care facilities. So both CS delivery and complication managed at appropriate facilities improved over time. This is because of improved coordination and bidirectional linkage at primary care facilities. Another interesting outcome is shifting prenatal mortality rates at district level. One of the innovations as part of this network of care approach, we designed and tested was the combined community facility quality improvement strategy, which is a district-wide strategy implemented both at the community, health post, health center, and hospital levels, and as a district improvement process. So this showed for the last 1.5 years, a reduced prenatal mortality rate by nearly 1/3. This is a big lesson, and we are scaling this initiative to other geographies as well. So the key lessons from this network of care approach is, I think, enhanced both administrative and technical connections across primary health care facilities and communities, and enhanced care coordination within a district health system, leading to optimized performance of the health extension program and primary care services, as well as improved healthcare access. And this initiative, this network of care, reoriented the primary care toward strengthening the community health program and instrumental in fostering trust, improved communications, and increased efficiency among all the stakeholders involved at the district level. And integration of quality improvement and community engagement strategies highlighted the significant benefit of collaborative efforts among communities, health facilities, and local authorities at Kabale and Warada level. These are the key lessons and takeaways that we learned so far from our implementation strategies. Thank you, everyone. If you have any questions, I will be available through this, and probably I will link my email for further questions. Thank you. Over to you, Dr. Antenna.
Thank you, Dessalo, for the excellent presentations and speaking on this important topic, particularly how the health extension program optimization is operationalized and pressure tested, and how the strategies are working, and with the network of care, improving the care coordinations and some of the results and sharing the lessons. We see questions coming, so we'll be addressing in the Q&A sessions. Thank you again. Without further ado, let me proceed to introduce our next speaker. This time we'll be hearing from the experience in terms of implementing health extension program optimization roadmap in the pastoral. Allow me to introduce to you Temesgen Ayobu, who is a primary health care director at Amref Health Africa. He holds a Master of Public Health in Health System and Policy Making. He has 15 years of experience working for the Ministries of Health and international non-governmental organization. Welcome, and over to you, Temesgen.
You are on mute, Tami.
Okay, thank you, bro, and thank you, Dr. Antenna, for the introduction. So my presentation will be a continuation of what Fondosan briefed us about the health extension program roadmap, and also Dessalo's presentation regarding the improved primary care service delivery activities in the agrarian context. So for this webinar series, I will be focusing only on the integrated mobile health service delivery that we are implementing in the pastoral context to optimize the health extension program. And hopefully in the upcoming webinars, we'll try to address also other implementation strategies. This will be the outline of my presentation, highlighting the pastoral context, so to have a better understanding of what pastoral looks like in Ethiopia, and also the policy context, more specifically at the national level regarding primary health care service delivery in the pastoral context, and a brief about actual profile that was actually presented by Dessalo regarding the improved primary care service delivery and the integrated mobile health service delivery approach that we are implementing in selected districts, the challenges of implementing this approach, and the lessons we have learned so far that will inform the scale-up and implementation by other questions. So just to give you some context about the pastoralist context in Ethiopia. So in Ethiopia, around, I think, 12 to 15% of the population of Ethiopians are pastoralists, and in terms of geography, around 2/3 of the land mass in Ethiopia is populated by the pastoralist population, and in terms of number, around 40 million people reside in these areas. And this pastoralist context is also characterized by limited access to basic infrastructure, which also has a limited access to education and also services like health services. And it's also manifested by harsh weather conditions, and also strong social networks are also common in these areas. And the major coping mechanism is mobility, so that the community travels from one place to another place due to erratic rainfall, recurrent drought, livestock disease, and loss of scarce resources. And there is also limited access and utilization of health service. So as we can see, for example, the life expectancy at birth in Afar, which is one of the most pastoral regions in Ethiopia, is 4 years below the national average. And when we also see the health facility delivery, 39% of mothers in Afar deliver in health facilities, while 99% of Mazar delivered in Addis Ababa. Similarly, in Somali regions, other region which is also populated by pastoralist people, the study shows that 65% of the population in that region is unable to reach a health center or a health post within 1 hour walking. So this shows the limited access and utilization of health services in the pastoralist context. And when we see the policy context in terms of addressing this challenge, mainly access and utilization, and also improving the primary healthcare service delivery, most of the national strategies and policies focus on tailoring the implementation strategies and also expanding or scaling the mobile health service delivery. To mention few, like the National Health Equity Strategic Plan, it recommends to tailor the health extension program roadmap that was presented by Wonderson, and also to expand and scale up the mobile health service approach. Similarly, the existing health sector strategic plan, which is called the Health Sector Midterm Development and Investment Plan, also included a strategic action to test, expand, and strengthen mobile health team approach in the pastoralist context. Similarly, the draft National Primary Healthcare Strategic Framework, which is under development, also recommended contextualized and also mobile health service delivery as a primary care model of care to improve service utilization. And one of the strategic documents, which is also which is our priority topic for today, the roadmap for optimizing health extension program in Ethiopia, under strategic objective 1, which is about improving access and expanding service package, recommends to contextualize the service delivery modality in the pastoral context and develop a model for mobile health service delivery. And using these also strategic documents and other learnings, also the Ministry of Health developed the mobile health service implementation guideline with the aim of standardizing and institutionalizing and scaling up mobile health service delivery, which recommends 2 types of mobile health service delivery approach. One is mostly a full-time mobile health team approach that travels with the community, and the other one is mostly a sustainable outreach strategy, so which is mostly based in a facility or a worada and provides a periodical outreach service to the community. So with this understanding, the improved primary healthcare delivery, actually this was presented by Dasalo, funded by BMGF, and with 3 primary outcomes: 1, ensuring equitable access to and utilization of essential health service, and also improving quality of essential health services, strengthening technical oversight and accountability. So under the primary outcome 1 of improving access and equitable utilization of health services, Amref Health Africa, in collaboration with regional health bureaus and the districts, we are working, design an integrated mobile health service delivery with the aim of testing context-specific mobile health service delivery to ensure equitable access to RMS health service, and also to document evidence for program learnings and scale up of mobile health service. And the implementation process includes first a rapid assessment where we assess the previous experience of mobile health service in 5 districts targeted for the mobile health service, and also identifying the distance of health facilities and also the populations that needs to be targeted to understand and also identify eligible communities for the mobile health service. And later on, a Worada-based or district-based co-design workshop was conducted that includes the district health office, the primary healthcare facilities, the communities, and also other relevant stakeholders to agree on the target, the population to be targeted, the frequency of the visit, and also the services to be delivered, and also the roles and responsibilities of each stakeholder were agreed during this co-design workshop. And based on the co-design workshop and rapid assessment, identification of communities and sites that should be targeted by the mobile health team were was identified, and later on, a mobile health team were established in selected health facilities that includes a team of health professionals. And later on, that was followed by a community mobilization every month and deployment of the mobile health team to provide the identified health services to the population targeted through this service. So with this approach, we also identified the key features of the mobile health service approach that we are followed. Some of the key features include, like, for example, in terms of governance, this approach is coordinated by the Warada Health Office, and most of the resources is also availed by the Warada Health Office, including vehicle, medicines and supplies, and also health workers also coming from the district health office. And in terms of reporting, the existing health management information system tools are used for recording and reporting purpose, and supportive supervision and regular performance review meeting is being conducted by the health system, but also in collaboration with AMREF. And we provide technical support and some logistical support, like fuel for the vehicles. And these are the service packages that are being provided. That includes under 5 children health service, immunization, family planning, antenatal care, postnatal care, and screening for malnutrition for pregnant mothers, adult patient diagnosis and treatment, and also other services including HIV testing and awareness, screening and awareness, hygiene and sanitation, and also referral of cases to health centers and also hospitals. The team composition mostly includes health officers, nurses, midwives, and also health extension workers. But in some places, laboratory professionals and pharmacists are also engaged. And the health extension workers and the village health workers, the village health leaders are also engaged in mobilizing the community and also communicating the service site and schedule for the community. So mostly this mobile health service is provided on a monthly basis. So the health extension workers and the village health leaders will communicate the schedule and also the site where the service is going to be provided. And in some places, like for example, Afar, traditional means of communication like DAW is also used to ensure meaningful mobilization of the community and improve service organization. So far, when we see the key achievements, we conducted 8 rounds of mobile health service provided in 5 targeted waradas, and we served a total of 48,828 people. And as you can see, starting from the 5th round, the number is only even for 2 districts, since some of the districts are not conducting some of the round visits due to other reasons, which I will mention in the challenge section. And when we see the gender as well, 58% of the people that are served through this approach are female, and 42% are male. And the type of services, 47% of the services encompass newborn and children health and nutrition. And the second one is immunization, which constitutes around 14%, and vitamin A supplementation and deworming contributes for 13%. Family planning, care for pregnant men and adult obesity, and postnatal care are other services that are provided through this approach. When we see some of the challenges that we are facing, some of the challenges, like for example, I said some of the districts that inhibits them to conduct on a regular basis is transportation challenge, or like for example, the vehicle may need significant maintenance, and some health facilities also face, I think, challenges. So rather than compromising the fixed health facilities, they may leave or they may discontinue providing the outreach service. The other one is inadequate or lack of dedicated budget from the Warada Health Office, and shortage of medication, security issues, and flooding are also some of the challenges. For example, as you can see from this picture, one of the health centers in Dafanach Warada, this is how the health center is affected by flooding. So here, flooding is also a challenge, but the mobile health team has also served as a strategy to provide services, for example, for the communities who are displaced by flooding. So by repurposing the service delivery modality or using mobile health service, the team managed to provide essential health services people who are living in IDPs due to flooding. And some of the key lessons that we have learned through 1 year implementation of this approach includes first, a comprehensive range of healthcare services were managed or delivered for vulnerable communities, mostly pastoralists, but in some places also IDPs. And we have learned that engagement of trained community volunteers or village health leader enhance the mobile health service effectiveness because they were able to mobilize the community and increase the service utilization. And we have also learned that the mobile health service helps to identify outbreaks within the community, as we witnessed in Dagahab Worada in Somali. And the other one is Worada-led in collaboration with local and state actors and communities are key for sustainability of this approach. And we believe that a robust information system is crucial for tracking impact and informing future recommendations. And we also recommend to conduct an economic evaluation, which is essential for scalability and sustainability. And right now, we are also actually working with Merck Evaluation, which is one of the learning partners for this investment. And they are conducting an cost effectiveness analysis for this approach because one of the major questions that many stakeholders face when it comes to the mobile health services is it cost effective? So hopefully this assessment will answer that one and inform the Ministry of Health and other relevant stakeholders and guide the future investment in mobile health service delivery in Ethiopia. With this, I conclude my presentation. Thank you very much, Anthony. Over to you.
Thank you, Tamasgen. It was wonderful to hear about the implementation in the pastoralist communities and the progress in the challenge, as well as the achievements that you were able to get in the lessons. We will be proceeding to the Q&A section. And the first question would be to Dessalo, and the question that came was in terms of, you have described about the network of care and the link to the health extension program optimization was raised as a question. What is the contribution of the network of care to the health extension program optimization?
Thank you. Can I respond to this question specifically?
It is basically about the network of care and its link with the HEP optimization and what's the contribution.
Yeah. Sure. So this NOC is primarily an approach where we bring public and private facilities in a district to provide support to community health program. That's one goal of the NOC, but not only the only goal. So the role of this network of care is bringing health center and hospitals. They establish a unit at respective hospitals and health center to provide support to the health posts. So they provide mentorship, supervision, training, capacity building training, and resources. I mean, equipping the health posts with medical equipment and furniture from health center and from hospitals, and they provide medical supplies and so on. So they provide capacity building, they provide supervision and mentorship, they provide resources from health center and hospital, as they do regular performance reviews, and they try to address those challenges locally. These are primarily the role of the network of care facilities in terms of improving health extension program. In addition, they provide training to the VHLs. Training to the village health leaders is provided by the health center and by the hospital team as well. So there will be, I mean, a technical hub for the health extension program in general. Yeah.
Thank you, Dassalo. The other question that came is for Temesgen. It's about if there is any lesson on the cost effectiveness of primary healthcare units on the identified high impact activities. I know you mentioned about the economic evaluation that's currently being underway and undertaken by Merck consulting firm, but is there any early finding in terms of the cost effectiveness?
Thank you so much, Antana, and thank you also for the question. I think regarding the learning for our implementation districts, hopefully we'll have an evidence regarding the cost effectiveness of the interventions on each implementation strategy, like regarding the comprehensive health cost, the community health program units, and also the community engagement strategies. But at the national level, I don't think there is a national level assessment that will inform this assessment. But for our districts, we'll have that evidence as soon as possible, and hopefully we'll share that one. But I think for previous health extension program implementations, there are studies on the cost effectiveness of the program, including the return on investment on the health extension program, which they can access it because since it's published. But for our districts, for our implementation districts, we'll have the evidence as soon as possible. Thank you.
Thank you, Temesgen. There is also another question that's aimed at you. It says, do the mobile health team have tools or protocols to provide some clinical care? For instance, a protocol for the adult treatment.
Thank you, Antana. So the mobile health delivery is an approach. So the health workers are mostly the health center staff or the hospital staff. So the tools and the clinical guidelines they use at the health center level applies also for the mobile health service delivery. So most of the mobile health team, like for example, they use the Ethiopian primary care clinical guideline to manage adult illnesses, and also they use other clinical guidelines for antenatal care and family planning that they use for at the health center level. So definitely they use this service, and for the question for the adult care, they use the Ethiopian primary care clinical guideline to ensure the quality of care.
Okay. It seems the other question is also towards you. It says why postnatal care service in the mobile health service is low, despite the expectations that most postnatal care would be conducted through outreach by the health extension workers. Any reflection on that?
Thank you. I think that's a great question. So nationally, also postnatal care is, I think the coverage is very low. And as you said, actually, through this service, this approach, since we are extending the service to the community, we may expect an increase in postnatal care service delivery. But here, what I try to show is the share of postnatal care out of the overall health service that we provide. Like for example, if I say if we provide 100 people, if we provide service for 100 people, it means 2 of them is for mobile health service. So it doesn't show the general utilization of postnatal care services, but only the services that we provide through the mobile health team approach. But this doesn't also replace the services that provided through health extension workers, through home-to-home visits, and also at the health post or a health center level. This is the only service that provided mobile health service. But I think this also needs probably further investigation and also a lesson for us to see how the mobilization and also the site selection activities are targeting women eligible for postnatal care. So that one we'll take as a feedback, but that's the reflection I have for the question. Thank you.
Thank you, Tamaskin. To the Salo, the question is basically to understand, but as Anderson has to leave for other, as he has another commitment, it is more on the practicality and what's going on in the agrarian context. The question is about the comprehensive health posts, and are they equipped to replace the health center? And for NTD services, can they be contacted? Can they provide NTD services in the other?
Yeah. Thank you. Thank you. This is a very important question. Yeah, the comprehensive health posts, they do have the service package they're supposed to provide, expanding the 18 health extension package. But based on, the expanded package, the human resource actually determined. So comprehensive health posts are equipped with or staffed with health officers, nurses, midwives, and they do have also one laboratory and one pharmacy professionals. So aligned with their scope of engagement, professional scope of engagement, they can handle most of the entities at comprehensive health post. But it doesn't mean it will directly replacing the health centers, but most of the activities services provided by the comprehensive health post is somewhere between the health post, the basic health post, and the health center. So some of the services may need the health center services, but most of the NTD services could be provided at comprehensive health post. Yeah.
Thank you, Dasalo. We remain with 4 minutes, and it might be good to conclude on time. I would like to thank the speakers for sharing your insight and experience. I know Faraz was not able to continue and finish with us, and the same with Wenderson, but they were able to share the experience from the global perspective. We will be sharing the resources as well, the PDF format for the presentations, as well as the Premier and other global products that Faraz was mentioning. As you can clearly see, in Ethiopia, what we have done with regard to the HEP optimization based on the finding on the National Health Extension Program assessment and coming up with the strategies giving due consideration for the change in the context, as well as the need at the community level with the changing preferences and needs, and trying to meet the needs in terms of quality and addressing equity, as well as the financial protection aspects and resilience. This is a wonderful strategy that's put forth by the Ethiopian Ministries of Health. And it doesn't mean all the strategies that are proposed could be functional. So that's why there is this important project, the Integrated Primary Healthcare Service Delivery, where they aim to pressure test and see what can work and what cannot, and if there is any adjustments that can be made to improve access quality through as has been described by both Tamaskin and Dasalo. We have tried to cover both the agrarian and pastoralist context and how healthcare can be improved, primary healthcare can be delivered, and how the community health program can be optimized in order to meet the changing need, as well as strategizing different modalities, including the community engagement approach by engaging involving male, using the social structures, as well as the incentive mechanism and revitalizing the existing health extension program. I hope we have gained lessons on this important topic. This would be one of the several webinar series that we will be having. We'll keep sharing lessons from the field, particularly from both sides. As a trusted and great partner, we are grateful for JSI and AMREF for sharing their experience. We will continue to do that. If there is any other points that I may have missed, if there is any pressing questions from the participants that I may have, maybe let me give opportunity for Bru if there is any questions that's missed and that should be addressed.
We are good, I think. Thank you. Thanks so much.
Thank you. Thank you everyone for attending this webinar. We are grateful. We'll continue to share the lessons and experience going forward. Thank you again, the speakers, and have a great day, evening, depending on where you are.
Thank you so much.
Thank you, Antana, and
Thank you all.
the IPHC team and everyone, every participant for your interest. Thank you. It was a great session.
Thank
Thank
you
you.
very much.
Very good.